waiting for the slides.
Well, fortunately, you've all got the document there, hopefully. So I just want to briefly, we're running a bit short of time anyway, so I'll go through this quite quickly. Go through some of the key stats there, and then I'd like to just discuss how we've actually got to where we are. And later on after lunch, we'll hopefully talk about some potential solutions. In fact, the publication does include some solutions, very important to do so, and I'd quite like some feedback on what people feel about those. But, of course, well, I think it's Picasso who famously joked that you don't just copy an artist, you steal from them. And so that's what we've done here. We've taken the idea from the Royal College of Physicians in the UK, who produced a similar publication in 2015, I think it was. We haven't included the same topics. We've included our own topics that we felt were most important. By no means comprehensive, of course. It's just really some of the key things that we felt needed to be highlighted, and of course there are many, many other things that we could have put in there, but we think you get the picture. Good. What was I going to say? Yes, well, the original document, the college document, also included a question mark. I mean, obviously we haven't included a question mark on ours, and I suspect if those of you who may be sort of keeping abreast with how the NHS is doing these days, I imagine that the college, if it were to do a similar publication today, they wouldn't include a question mark in the title either. But we're running short of time, so I'll go through these quite quickly, and then we can have some further discussion later. So the rise in acute admissions, twice the rate of population. There's one graph that we haven't included in the publication, which on retrospect I wish we had done, and that's the increase in the number of consultations in primary care that have occurred. This is including GPs and nurses. Consultation rates have increased at pretty much the same rate as that middle line there. For those who, hopefully, well, you can read your document anyway, but the lower line is the population increase, the middle line is the case rate increases, and the blue line the actual increases. And the rate of increases in primary care consultations rose pretty much in line with that middle line, so very much higher than the population increase over that time. And I mentioned that because the government is really, really strongly pushing this idea that you can relieve pressures on hospitals simply by improving primary care and prevention in primary care. And of course, while that's good to do, it certainly doesn't have the impact that they think it's going to have. And as we see here, and in fact the same things have been happening in other places like Australia and the UK. So emergency department attendance is 1.2 million in 1918-19. Again, increasing at twice the rate of population over 9 years. Same story with mental health. And this year's budget, the severe end needs mental health services were cut by 55 million in real terms in order to pay for services focused more on the less severe needs. But I think clearly what we're going to see is more and more pressure on those severe end needs, those hospital services in particular. Bed occupancy rates. As we all know, 85% is the accepted standard. OECD shows that New Zealand is well below the number of hospital beds per population. The number of acute beds per population is continuing to decrease as the acutes are increasing, of course, and as the population is increasing. So, you know, the trends are obviously conflicting. Canterbury Hospital, even the planning of hospitals today is really not taking into account the reality of this. You know, and it's been well reported in Canterbury that, you know, their new $500 million facility there, which is, I believe, going to be finished next year, may just about meet the needs next year, but by 2024, I think it's estimated that there'll probably be about 120 beds short. So, you know, we've just got some crazy planning happening. Well, I think that tells its own story, really. Psychiatric inpatient beds, New Zealand way down the bottom there. Now, this was included as a late addition, so I had to rely on the readily available data, which is why we've got two lines there. The first is data from the Health Quality Safety Commission, and the second is from the Ministry of Health. Of course, you know, there are lots of reasons for readmissions, but when you look at all of the other data, you know, you have to ask, well, could this be related to the low bed numbers, the high acute admissions, the staff shortages? Also, in fact, something that we haven't included in the publication is that New Zealand has one of the lowest average length of stay figures in the OECD. It's about fourth fourth lowest. So when you put all those things together, there's almost certainly some connections there. Interestingly, the non-acutes have been increasing lower than the rate of population, the actual acutes, and that suggests that, I mean, the case rates are higher. That suggests that the rise in acutes are squeezing out the non-acutes, the elective surgery and so on. Can we have some discussion later? But also, of course, the budget cuts as well are affecting that. And, of course, that's impacting on unmet need, because we know that people aren't getting their elective surgery on time. We heard the story from Julian earlier about, you know, people being sent back to their GP because they don't meet the threshold and so on. This figure of unmet need was based on Phil Bagshaw et al.'s work, which estimated about 9% of the population had an unmet secondary care need. And it's pretty consistent with the data that's put out by the Private Hospitals Association and one or two others, commissioned work looking at unmet need for surgical care. I actually feel that's probably a conservative figure, if anything, because I think we've got, you know, people who probably wouldn't survey as having an unmet need because they're in the system, probably do actually have an unmet need because they're going round and round in the system. The interesting thing is really that we've never really had an official measure of unmet need, a routinely published measure of unmet need. Until Phil Bagshaw came along, we had no idea really. You know, how do we know how well the health system is serving the population if we don't know what the unmet need is? I mean, it's an appalling situation really, and especially because we have an idea that it's pretty big. So one of the recommendations that we've included in the publication is for that to happen. I mean, the easiest way, the most obvious way, is to include some questions in the regular New Zealand health surveys like they do with primary care. Of course, another reason is funding. Now, this isn't the graph that we've published in the publication. I've used this one because there is starting to be a kind of sense of denial that there's ever been a funding cut. If you read the Health System Review's interim report, it kind of suggests that we haven't seen a real funding cut. It's actually sort of been fairly flat over recent years. But in fact, a few years ago, the Labour Party, when it was in opposition, did commission some. In fact, they commissioned two studies from the Informametrics consultants, and this was the later one, published in 2017, I think it was. And this is what it showed, basically, an accumulative $2.3 billion cut over that period. And of course, the ASMS CTU regular analysis of the Vote Health budget has, shown similar cuts of similar proportions. So, this is really happening, and of course, that contributes to what we're seeing at the moment, which has been talked about a lot, about the SMO staffing shortage, 24%, on the information that we've got at the moment. So. Now, there are a number of reasons for this. Partly, a lot of this information is invisible because it's not regularly published by the Ministry or the DHBs. We should be seeing regular reports of bed occupancy rates. We should be seeing regular reports of acute admissions and ED admissions as well. They should be up there in the headlights regularly. Not just the figures that the obscure figures often that the Ministry of Health decide that they want to put up there. So we need some more data, and for it to be regularly published. There's a big issue that goes back over not just recent years but decades. Really, is that the health system has been served really poorly by policymakers. We've just had such real bad policy. And if you go back over the decades, we've gone through privatisations, restructurings, amalgamations, the imposition of simplistic, narrow targets that, motivated by political interests rather than health ones. And very often policies that are suited more to 3-year election cycles than to health, to what's best for health services. There's also, when you read a lot of these documents over the years, you really do get a strong sense that there is an entrenched ideology that hospital, as I said before, hospital pressures can be addressed by simply putting the resources into primary care and into prevention within the health system. And of course, it's much more complex than that. Now, I'll just go further down because we're running out of time. So there's also, I think, a political culture of austerity, which again is entrenched. We have very good well-being policies with very good, very, very good aspirations, big aspirations, but a small idea on the investment that's needed for it. If you look at Scandinavian countries, people have mentioned Scandinavian countries before, Denmark, Norway, Sweden, of course, are well known for their well-being approaches. When you look at how much they spend, or the government in those countries spends on health and disability services, and you compare it with New Zealand, I mean, we're way behind. I did a quick calculation, just looking at the averages of those countries, just looking at health and disability, government spending, total spending, and to cut it short, if in 2018 we wanted to be on a level with those Scandinavian countries in terms of how much we spent per GDP, we would have needed to have spent $4.3 billion more than we did in 2018. I mean, that's how far we are behind. I mean, hugely. Now, I just want to talk a little bit about the Health and Disability Review, because the interim report to the Minister that was published in early September, because it kind of to me, it sort of, even though it doesn't give any recommendations and it's very vague on a lot of things and it includes a lot more questions than answers, there is a narrative running through it which seems to be along the lines of very much what we've already been seeing and what is causing these problems. And it's also a narrative that we've seen in the past, before restructurings occur, i.e. that the current health system is unsustainable and that we've really got to change it. And again, it's more away from, there's also with that narrative is this kind of aversion to hospitals almost. In fact, not just hospitals, but also doctors. This quote here from the review talks about how unsustainable everything is, but it also talks about how if we increase the number of staff overall, and it talks about doctors and other places, that actually that wouldn't be sustainable either. And it goes on to argue that the reason that it wouldn't be sustainable is because the health and disability workforce, which they estimated was currently between 8 and 9% of the total employment workforce in New Zealand, would increase to about nearly 11%, by 2030 or something. And they say that would be totally unsustainable. So that didn't sound right to me. So I checked it up and looked at the figures, the international figures on, what proportion of health and disability workforce was as a proportion of the total workforce in other countries, in particular Scandinavia. And what I found, in fact, an unsustainable level, according to the advice given to the minister, is around 11%, the health and disability workforce as a total of the total workforce. In Norway, for example, it's just over 20%. Denmark and Sweden are around 17%. So it kind of is a good example, really, of the narrow, very fiscally oriented approach that we have towards, aiming towards these very high aspirations of well-being. We really do need a quantum change in that attitude. As I say, so often you see, including in this review report, so often you see in the documents hospitals referred to more as and hospital doctors especially, more as a kind of overhead than a valuable asset and an enabler of health services. So here are a couple of other things I pulled out of the review report very quickly, that hospitals have dominated the system, and they're putting this because of hospitals that the health system's under pressure. Incredible, really. DHBs may be biased towards spending in their provider arms, and of course it's because employees, and they're talking about doctors here, have influence on how they spend their money. Now I haven't got time to go through, so maybe we do this afternoon, but I mean I've done some sums on that and it's rubbish, So here's a lovely one. Clinical workforces are expensive, medical workforces are even more expensive. Senior medical officers spend all this time on holiday and leave and stuff, Now this is a precursor to an argument again about how expensive hospitals and doctors are, So it's kind of, the health review report. The health review report, the interim report to the minister, calls itself a reality check on how things are. So this is the kind of reality that they see. Now, I realise I've run out of time, so I just want to contrast that earlier quote with one from Hospitals on the Edge, from one of our members. And I think, it illustrates just how far the reality, according to the centre, is, the policymakers is, compared with what the reality on the ground is. And now, you know, I think we get the general picture that the system is under the pump, and so are its staff, not just the doctors, but everybody. And so, in pointing all this out, of course, it's important to also include some solutions, and so that's what we've done here. And I hope we get some time to, you know, just get some feedback on some of what we've proposed in the document, some of the solutions. Some of them are obvious ones. You've got to put more money in, we've got to put more staff in, and so on. And we're also going to hear some more stories, as Charlie mentioned, from a panel of members, and I really appreciate that very much, because it's not, you know, not the easiest thing to do. And as Charlie said, I think, you know, expressing to a stranger your kind of your private experiences when you've been feeling so vulnerable about, you know, what's happening to you when you're really under the pump day to day is not necessarily an easy thing. And you know, when you see it pasted in letters at a conference, it probably makes whoever said that, if they're here, they may feel uncomfortable about that. But I would say to those people, I mean, I know some of them are here, that, you know, you ought to feel really proud of contributing the way that you have to this document. I hope that it encourages others to speak out, and I really would like to have some discussion about that after lunch, because I think if we're going to get these messages out consistently and over time, then we really do need to hear the voices of doctors much more. And I mean, I know that it's an issue, it always has been an issue, and we need to find a way around the barriers to that. So I would just like to conclude, you know, just to add to Charlie's thanks to those people who contributed. It's just been enormously valuable. You'll probably know that this document received phenomenal media coverage when it came out, and I don't think it would have done had it not been for those quotes through the document from members, because it just grounds those boring old statistics into a reality, a real reality, not the centre's but ours. So, you know, a big thank you to those people. Okay, thank you.